Good afternoon, and thank you for inviting me. I've been asked to make a presentation to you about what we know about health inequalities, the existence of variations, disparities in health between people with a different socioeconomic status, indicated by education, occupational class, income, but also to talk about the causes of these health inequalities with a focus on the built environment. So that's what I'm going to do. I'll introduce the topic to you and then move on to discuss the role that the built environment can play in the generation of these inequalities in health. And these inequalities in health are extremely persistent and universal. You can find them in the strangest places, even in movies like the movie on the Titanic. Many of you will have seen the movie with Kate Winslet and Leonardo DiCaprio. And there are scenes in that movie that reflect the evidence here on the slide. The fact that first-class passengers, like Kate Winslet in the movie, had much better chances of survival than third-class passengers like Leonardo DiCaprio. This comes out of the official investigation that was conducted after the sinking of the Titanic, that first-class passengers had a bigger chance of survival than third-class passengers. Even then, in such a disaster, there were enormous inequalities in health, in survival in this case. And these inequalities are still present at all scales at which they can be studied. They are present at world scale, indicated by life expectancy at birth, for example, which varies enormously between countries that are richer or poorer. Here in this map, you see the average income in dollars per year of different countries in the world. The darker countries are richer, not difficult for you to recognize. And these richer countries also have higher life expectancy at birth. The purple countries here on this map are the ones with a life expectancy at birth of over 78 or over 80 years. And this association between average income and life expectancy at birth is extremely strong and persistent. It has been there for as long as we have collected these data. And as I said, these inequalities are present at many different scales. They're also present in the city in which I live and work, in Rotterdam. What you see here is a map of the metro system of Rotterdam, and on the right-hand side, the life expectancy at birth of the neighborhoods that are crossed by the B line of the underground. And when you travel from one station to the other, you can experience a drop in life expectancy, or to put it in better words, you travel through neighborhoods with very different life expectancies at birth. Along the B line, the richest neighborhood is this one, Kralingen-Oost, which has a life expectancy at birth of 78 years. And when you travel on towards Kool and Delfshaven, life expectancy at birth drops by 4 years. Delfshaven is the poorest neighborhood in Rotterdam. And this association between the level of income by neighborhood and life expectancy at birth can be seen here in the two graphs, on the left-hand side for men, on the right-hand side for women. These are phenomena that can be found in all cities that take the trouble to collect these data. And most of these inequalities that we see between countries, but also between neighborhoods, are due to the fact that individuals with a higher level of income or a higher educational level or a higher occupational class live longer than individuals with a lower income or level of education. Fortunately, we have these individual level data also in the Netherlands, and this is what we see when we calculate life expectancy by level of education in the Netherlands. For men and for women, the blue bars and the red bars, and the 4 sets of bars represent the 4 different levels of education, from low education on the left-hand side to tertiary education, post-secondary education on the right-hand side. And as you see, life expectancy is consistently higher for individuals with a higher level of education, both among men and among women. It's about 5-6 years difference in life expectancy, quite a substantial inequality. And it's not only life expectancy, it's not only mortality that differs by level of education, it's also the incidence and prevalence of many different health problems. And when we combine mortality with incidence or prevalence of health problems, of diseases or disabilities, we can calculate measures like life expectancy without disability, as in this graph, and as you see, the levels of life expectancy without disability are lower than those of life expectancy as a whole. People spend a certain part of their life with disability, but here again we see a gradient of higher life expectancy without disability for those with higher levels of education, and actually the gap is much wider than in the case of life expectancy. Here the gap is between 10 and 15 years between those with the lowest and the highest level of education. And this gap becomes even wider when we take another measure for health, life expectancy in good self-assessed health. Here the gap is around 20 years. People with the highest level of education live 20 years longer in good self-assessed health than people with the lowest level of education. And that's bad enough as it is, but the inequalities are also not improving over time. They are not becoming smaller over time. While life expectancy increases over time, like in this graph between the late 1990s and the most recent year for which data are available, 2014, life expectancy increases by about the same extent for those with lower and those with higher levels of education, and the gap between the lowest and the highest level of education remains more or less the same. So while there is improvement for everyone, also for those with the lowest level of education, the improvement is not strong enough to remove the inequalities in life expectancy. It's not strong enough to remove the inequalities in life expectancy. It's not strong enough to remove the inequalities in life expectancy without disability, or life expectancy in good self-assessed health, or life expectancy without chronic diseases. The gap remains the same and even tends to widen somewhat for some of these indicators. And the fact that the people with a lower level of education die younger and have more years with disability or chronic illness than people with a higher level of education is due to a higher rate of occurrence of almost all specific diseases. This is a really amazing thing, that whatever disease you look at, it is more frequent among people with a lower level of education or a lower level of income or a lower level of occupation. Here is a list of some of the diseases for which we find that, and also for the two only exceptions in the Dutch population, breast cancer and allergies. And there are explanations for these exceptions. For example, the fact that higher educated women delay childbirth more than lower educated women, at least until now, which then produces breast cancer inequalities that are the reverse of the inequalities that we see for most other diseases. But for most diseases, we find that they are more frequent among those with a lower socioeconomic position, and this is regarded as one of the greatest paradoxes or puzzles of public health, that despite the fact that prosperity has risen so much over the past 20, 30, 40, 50 years, despite the fact that we have created very good systems of social security in the Netherlands and other Western European countries, the fact that we have created an accessible healthcare system with perhaps some barriers for access, some financial barriers, but with overall quite good access to healthcare for everyone. Despite all that we have done, these health inequalities persist and are even widening on some measures. Now, what is the explanation of the persistence of these health inequalities? And that is actually a difficult and complex story. There is not one single cause or determinant that explains these health inequalities or their persistence. But when I try to summarize in just a few sentences why it is that these health inequalities are so persistent despite the rise of the welfare state and all the measures that I've just mentioned, there are three types of explanation, 3 groups of explanation that account for the fact that these health inequalities are still there. The first is that although one may tend to think that it's low socioeconomic status that causes ill health or premature death, the reverse can also be the case. Sometimes health problems lead to downward social mobility, to people losing their jobs and losing parts of their income, and therefore produce an association between income and health problems that is not due to the effect of income on health, but due to the effect of health on income. That's one partial explanation or group of explanations. And the second one is that although it may be true that the welfare state has removed some of the sharp edges of material inequalities, material living condition inequalities are still very much there. People with a lower level of education live in less well built neighborhoods, they have lower incomes and sometimes relative poverty, and all that may be a barrier for healthy living. And the third group of explanations is immaterial. It's not only material conditions that determine whether you are healthy or not. Psychosocial stress may play a role, social networks, health literacy, and these inequalities and immaterial living conditions are also still very much present. And these 3 things together more or less explain why health inequalities are also still with us. And they are very, very much present in one of the most important determinants of premature death or illness and disability, health behaviors like smoking or obesity or lack of physical exercise. Take, for example, sports activities. These are much more frequent participation in sports activities among those with the highest level of education than those with the lowest level of education, which is explained by the factors that I mentioned previously, partly by access to facilities, partly by immaterial things like health literacy and so on. And this can also be illustrated more specifically for smoking, which has been studied very intensively. People with a lower level of education smoke more than people with a higher level of education, and this is one of the main specific determinants of why people with a lower level of education live shorter lives with more disability than people with a higher level of education. And again, this has a rather a complex explanation. It's partly due to the fact that at schools of lower levels, there are more children who smoke, who then produce social norms at these schools that make it more difficult for children to refrain from smoking. It's partly due to the fact that our campaigns to reduce smoking have been more effective among higher educated smokers. All campaigns that make use of information and communication tend to be more effective among people with a higher level of literacy. It's also partly due to the fact that people who live in unfavorable material living conditions experience more psychosocial stress, which makes it difficult to stop smoking. It's a whole range of factors that make lower educated people more likely to take up smoking and less likely to quit smoking than higher educated people. And this is summarized in somewhat different words here on this slide. So it's a complex story, the explanation of these health inequalities and their persistence. And despite the fact that it's a complex story, many people agree that these health inequalities are undesirable. They are undesirable for 2 main reasons. First of all, because they are a cruel embodiment of social inequalities. They are the consequence of the existence of social inequalities in our societies. And while many people will not object to the fact that higher educated people have a higher income than lower educated people, many people will object that they also live longer. Why is it necessary that higher educated people live longer than lower educated people? It's a somewhat cruel embodiment of these social inequalities. And the second reason why they are often regarded as undesirable is that health inequalities in themselves may cause social inequalities, because health is a barrier for paid work, is a barrier for, or ill health is a barrier for fulfilling your educational possibilities, and so on. So yes, health inequalities do matter. For that we need a better understanding of what they are due to, and also entry points for policies to tackle them. And here the built environment, I think, comes in. Which brings me back to Rotterdam, where we saw these large differences in life expectancy and also healthy life expectancy between different neighborhoods, as I mentioned a few minutes ago. And the question can be asked to what extent these inequalities in life expectancy and health expectancy between neighborhoods are due to the neighborhoods themselves or to the people that live there. Is this a matter of the composition of the neighborhood or of the context in which people live? And over the past 15 or 20 years, an enormous body of research has been built up to try to answer this question, because it's so obvious when you travel through Rotterdam or through other cities that one sees that the living conditions of people in poorer neighborhoods are really very different from those who live in richer neighborhoods. These are photographs of the neighborhood of Delfshaven, which I also mentioned as one with a rather low level of life expectancy among the neighborhoods in Rotterdam. And in the research that has been done on this relationship between the built environment of these poorer neighborhoods and the health of people who live there, 3 plausible relationships have been identified. And this is summarized in this diagram. Relationships through the natural environment, through the social context that is created by the built environment, and through a number of behavioral aspects. And along each of these 3 mechanisms, the urban built environment may influence the health of people living in poorer or richer neighborhoods. And these are a number of examples that come out of the research that has been done in this field. I mentioned 3 different mechanisms or plausible relationships that can play a role in the relation between the built environment of poorer or richer neighborhoods and the health of the people living there. The first is through the natural environment. A built environment can create a better or a worse natural environment in health terms. For example, through climate. Built-up areas tend to be more sensitive to heat waves. Through noise, through lack or availability of green spaces, which may then have health effects, for example, through opportunities for physical exercise. That's one plausible relationship that has to some extent been found in the research that has been done. Poorer neighborhoods tend to have worse natural environments in many countries, and aspects of this natural environment in their turn have sometimes been identified as causes of ill health in poorer neighborhoods. The second mechanism is through the social environment. Certain areas are more promotive of social cohesion than others. If you build neighborhoods with very uniform houses, you can promote segregation, and in some studies, segregation has been found as a risk factor for health problems, and the built environment can also promote or be a barrier for safety, both in perceived terms, but also in terms of traffic safety. That's the second mechanism, and then the third one is more directly through the promotion of healthy behavior or unhealthy behavior. Certain neighborhoods may promote physical exercise, as I already mentioned, but there may also be an influence through alcohol and tobacco consumption by the availability of outlets for alcohol and tobacco in certain areas more than in others. And healthcare access may also be a consequence or be affected by differences between poorer and richer neighborhoods in terms of the built environment, of the fact that there are healthcare facilities in a neighborhood, or the distance to travel between the neighborhood and healthcare facilities. And while these relationships are all plausible, I must also tell you that in the most authoritative reviews of this study area, it is also a consensus at this point in time that while it is plausible that the built environment mediates some of the effects of low socioeconomic status to ill health, the contribution to health inequalities at this point in time is still largely unproven, mainly because it's very difficult in observational studies to be sure that what one sees as an association between living in a particular neighborhood and a health outcome or a particular behavior is a causal effect of living in the neighborhood or of the fact that people who prefer a particular type of environment move to a neighborhood where they find it. And this possibility of reverse causality can only be removed by experiments, by natural experiments or by real experiments. And these real experiments are very, very scarce. They are, of course, difficult to do. How can one randomize individuals across neighborhoods? And it's only our American colleagues who have a rather more drastic approach to many areas of research. It's only our American colleagues who have done a number of experiments in which they have, in some random way, tried to move people from worse to better neighborhoods and then try to identify the health effects. And this is an example of a paper published in the New England Journal of Medicine. It's one of perhaps 3, 4 of such experiments that have been published that found that if you randomize women with children to receive or to not receive a subsidy that allows them to move from the poor neighborhood in which they are living to a richer, better equipped neighborhood, that 15 years later, the women who received that subsidy and who then have moved to a better neighborhood have a lower likelihood of being obese and having diabetes, possibly through better opportunities for physical exercise in the better neighborhood. This supports the idea that where you live does indeed causally influence your health behavior or your health outcomes. But these examples, as I said, are still very, very rare. Despite the lack of completely convincing evidence, I think it's very important to consider the role of the built environment in the generation of these socioeconomic inequalities in health. They are extremely persistent, frustratingly persistent. Tackling them requires an integral approach, and I think urban planning should play a role in trying to reduce these health inequalities, and therefore more attention to the health effects of the built environment is absolutely necessary. Thank you very much.